Right, so should we make a start then? We've got 3 presentations to get through with our usual timing to be done through by 1 if we can. So can we start then? We've got Helen first off, if we could.
Okay.
Oh, and Linda, thank you.
Hi, I'm Helen Lynch. I'm the pharmacist validating most of the rheumatology home care in Chapel Allerton. Linda Bailey's probably on the call, but she was also a process owner. So just a little bit of background. Just to Leeds Teaching Hospitals medicines expenditure for 2023 was approximately 300 million, with over half of this attributed to home care medicines. The home care service has significantly grown over the past few years, expanding by 50% since 2019. And the reason why rheumatology was chosen to be involved in this project was because it represents the largest cohort of patients within this service, currently managing around 3,500. Before the initial rapid process improvement workshop, the process was observed to be conducting in silos with limited collaboration between teams in flow, and this led to batching, bottlenecks, delays in prescription validation, and generally low morale within the team. Managing the workload for 3,500 patients is a substantial risk, given the limited staffing resources available to meet the demand. The goal for this multidisciplinary team event for the Rapid Improvement Week was just to understand the challenges and pressures of the service and come together during Intensive Improvement Week to transform the service, demonstrating teamwork and a commitment to improve patient care. So just to look at the 3 target process improvements. So in the recent process improvement, we identified the overall lead time for a single prescription to move through the process and complete the process has been significantly reduced from 24 days to 9 minutes, a remarkable improvement. However, as with all improvements, the challenge lies in embedding these changes effectively. After the initial 30-day period, we remeasured the lead time, and while it hasn't maintained the 9-minute mark, it is stabilized at 9 days. We feel that this is a significant improvement and a testament to the progress made in the 30 days. So work in progress, initially identified at 750, has also seen a reduction to 662, marking a 12% decrease. And at 30 days, this reduction is commendable, especially considering the challenges faced during this period, including enhanced annual leave and sickness, which have impacted the overall lead time and the work in progress. It's important to note that the highest concentration of the work in progress remains at the pharmacy stage, largely due to staffing resources. So that's a continual challenge and one which we shall be addressing at 60 days and 90 days, and we hope to show some improvement. So things left to look at. We have established a multidisciplinary area in the hub with the kind offerings of outpatients. So it's in the outpatients in Chapel Allerton. And because the room initially, we didn't know how it was going to be until we got in there. So the next challenge is the expansion of the hub into the second area to provide a more conducive environment for staff to allow them to manage continuous flow, which was the main sort of thing that we discussed in the Rapid Improvement Week. Now, sustainability remains a challenge because we send out letters and chase bloods for staff. So we've started envoy training for the nurses and the administrative staff, and we haven't got everyone completed, but we hope that this will be completed by 60 days. And it's been difficult over the last month due to holidays and staff sickness. So we were originally going to use the tracker system, which identifies where in pharmacy a prescription is using a barcode and a scanner. Now, because we're all into one area and we're a multidisciplinary area, we've taken a team decision to stop entering home care on the tracker. So as all prescriptions will be processed through the hub, we'll all be together and we'll be able to pinpoint where the prescription is at any one stage. And this will be very good for patients. So the key learning, for us, because we've brought together 3 teams, we need to keep all staff informed at every stage to achieve end goals of patient flow and improve staff morale. To achieve number one, we need an online communication logger, and we're popular users of Trello boards in pharmacy. So the next step is the expansion of the hub into the additional space, terminal points, etc., desks and phones for the nurse prescribers. And thanks to Chapel Allerton management, these are all ready. We just need to put the points into the additional space. Pharmacist cover needs to be reviewed regularly. The present state is 5 sessions per week, and the pharmacist manager plans over the next coming months to introduce half sessions as in addition. So each team needs to have a rota available for other teams to view, and the 5S agreement we need to display in order to maintain staff engagement and increase staff morale. You'll see from the targets that we had a very low staff morale at 0. We reintroduced the questionnaire for the staff, and it has actually gone up to 25%, which I know doesn't sound a lot, but starting from 0, that's definitely an improvement. And I'd say that we're definitely on the way to continuous improvement for patients and staff.
Brilliant, thanks, Helen. I think that's really great, and I think great progress, I think, in 30 days, given the scale of the challenge that you've taken on, as you articulated at the beginning, in terms of just the scale of the Chapel Allerton operation in this space. So I think really good, and some really good reflections there on the people elements of that. So thank you. I'm sure there'll be questions for you, Helen, but we will move on to the first start Kaizen event for paediatric theatres. I'm not sure who's with us, Bev.
Yeah, that's me. And Nalini is with us as well. So we're just going to talk through the slides, if that's okay.
Yeah, lovely. Thank you.
Okay, thank you. So, so as I said, the first, so the progress report so far. So originally we looked at, we calculated the baseline using just 1 week of data when we started the project. But looking at data over the last 60 days, there's been some benefits to the changes and the efforts that the staff have made and been involved in. We've looked at data from February to July, that's the end column, and the number of late starts have, we've got a 48% reduction since February. The cases which overran in the same period, 25%, and the changes to the order of the list, we've got 82% improvement. So we are moving in the right direction, and we felt it was necessary to give you sort of a baseline from February to July, even though we didn't start the project till June. Just so that we could see the actual movement. So what we've done is we've graphed it here just to make it a little bit more user friendly. So as you can see, in February the late starts were number of late starts, we had 93.3%, and then into July we're on 24%. So number of late starts, 7 cases in July, which is a significant improvement. As you can see, between April and May there was a drop, but we'd already started looking at the data there, although we hadn't launched the actual project at that time, but we felt it was necessary to put that data in. So some of the while we're looking at the data, we're also asking staff to put in narrative, and we've shared the purpose of the aims and the objectives with the theatre team, and we've noticed the improvements. We're continually making small changes which are resulting in further marginal changes, and constantly reviewing the data when we've got these reasons why. That gives us something to work with rather than assuming what's happened. We know, because this is the narrative, that the details that the staff are putting into their documentation during the list. As you can see, we're working on them, and we can tick them off or tweak or ask staff for their opinions of what we need to do to improve on those things. So Nalini is going to talk through the consultant anaesthetist engagement.
So just so there's a bit of background, we targeted the ENT list, the pediatric ENT list, to see how we can improve on our start times. The reason the ENT, pediatric ENT list were chosen was we have a massive problem there. We have about more than 400 patients waiting to have their tonsils and adenoidectomies done. So there was a massive issue, and we wanted to find out from our consultant colleagues what stops them from starting on time. And there were many different issues that we had little control over. And one of the biggest problems was streamlining the flow of patient across the entire patient pathway. There isn't a functional pre-assessment service for children at the minute, and this causes a lot of delays on the day. Consultants start at 8 o'clock in the morning and have to review about 5 patients on the list, and children and parents may not be prepared adequately for their hospital appointment or their impending surgery. Scheduling was a massive issue. The order in which the kids were listed was also a problem because we could have inpatients scheduled before the outpatients. And if we had to wait for an inpatient bed, that led to massive delays. All this was fed back by the consultant body. And also consultant staff were constantly helping staff on Ward 49 and the admission lounge to weigh patients, apply local anesthetic cream, so these children can be prepared in a timely fashion. So we were compensating for lack of nurses on the ward. There were also problems with functioning laptops, speeds of internet connections, and these were all highlighted by the consultant body. And so we set out to improve some of the low-lying fruits. So we have engaged with the other, the ENT colleagues to see how we can make the scheduling process better so that patients are populated at least a week ahead of time, and then the patient who needs to be first on the list is identified the day before and confirmed with both theatres, anesthesia, and the surgical team. So that work is ongoing, and that has helped massively in reducing the confusion that arises on a morning. All the discussions that need to be had have been smoothened by introducing this process. Admission ward staffing and the IT issues on the admission ward, we worked with the colleagues on the wards to find out how we can use some of the existing laptops which are on the drug trolley, which were not adequately used. They were the nurses were using the iPads anyhow. So it's seeing how we can increase the number of laptops that medical colleagues can use to access PPM and prescribe in a timely manner. There are problems with escort that have been identified, and the stocking of the anesthetic drug cupboard and other things that kind of delay the start of the list have been identified and being worked on, and this has helped to pick all the low-lying fruits. However, we identify that the smooth flow of patients needs to happen all along the patient pathway, and there are improvements that need to be made, which are continuously going through a process of improvement. And following on from this, we've applied for a leadership fellow to hopefully start in August. And this is a joint bid between the trust and the deanery. And this is how we see that we can contribute to making sure that we continue the process of improvement along the patient pathway to help our patients get timely surgery.
So we've got some joined up thinking, and Nalini and myself and the rest of the team are working together. But now we're looking at focus areas for theatres and anaesthesia. So as Nalini's already said, we're looking at the number of patients on the list and the order of the list. We're looking at theatre equipment and stock levels. We're being allocated beds in a more timely manner. That's improved. We have that 8 o'clock meeting with the ward matrons. The poor communication, regular evaluation of the progress and update for teams, so ensuring that the message gets out to everybody if we've tweaked anything, and we're trying to encourage engagement from and buy-in from all the other specialities. All these, many of these things are discussed at scheduling, as Nalini has said, and we can iron them out on the Thursday before the following week, which helps us with a better sort of start process, if you like. We're remaining positive, and we're keeping going. So the next step for the team is we're focusing on what we're doing well, and we're celebrating the successes. That boosts morale. If we see we've got a little win, we're okay there, and it helps people to keep motivated. We're continuing to review the data and implement the changes where possible and where necessary. We're communicating those changes, and we're empowering theatres and anaesthetic staff in problem solving. The anaesthetic drug cupboard, standardising and stock levels are all being addressed, and all the shortfalls dealt with. We're continuing to engage with all the interested parties, pre-assessment, staffing, digitalisation, IT issues on 49, wards, staffing, etc. We're accepting that not everything is within theatre's control. However, we're continuing to build on the relationships, the collaboration and the teamwork. As Nalini said, there's an application for a leadership fellow, so that we can prep well in children's surgery pathway. And we're all striving for efficiency, and there are benefits for our patients, our staff health and well-being, and our organisation. So we're going to keep trying. So finally, thank you for listening, and we're going to see you all in our 90-day report out.
So let's just quickly move on, get our final presentation, then we'll come back around for questions if we could. So who's leading off on this for us?
It's me. So hi, for those of you who don't know me, my name's Fran. I'm the advanced clinical pharmacist for chemotherapy e-prescribing at the Trust. So as I'm sure many of you know, that we use Chemocare to prescribe our SACT, our systemic anti-cancer therapy, at Leeds teaching hospitals. So to apply my LIM knowledge, I thought it would be good to lead a digitalisation project of the SACT adverse event recording. So we decided to start small with a small test of change alongside the GI nurse specialists. Big thank you to Anne-Marie and Amanda, who massively helped lead the project alongside myself on the pre-assessment nurses in J80. So a bit about what we did. So the problem that we came across, previously our nurses were recording chemotherapy adverse events on the paper chart that you can see on the right on the next slide. Obviously this is not ideal because it doesn't link to the Chemocare where the patient's medicines are prescribed. And as you can see from the chart on the left, there was a lot of duplication of work in that the nurses are using 4 different systems to record all of the patient's adverse events, which they found really time consuming, as well as really frustrating when it came to sharing audit data nationally. They would have to manually go through patients' adverse event data, which was super time consuming. So wasn't really possible with the staffing resource that we had. So I wanted to try and help. So if you go to the next slide, yeah, as you can see, just a bit more about the frustrations with the current system. So what are our actions? What we did was converted the paper chart to some chemotherapy e-profiles for adverse event recordings that you can see on the left here. So we did a PDSA cycle. I went to J80. I spent some time with the nurses and did some direct observations of their clinics and their prescribing practices, looked at the sort of steps they took and saw how we could minimize the contact with the number of systems. We did realise that there'd still have to be a small duplication of work with recording both on PPM and on Chemocare, because not all of our colleagues have access to Chemocare, and we do want all of our colleagues to see this kind of data about adverse events when a patient comes in an emergency, for example. I also used the waste management identification tools to help me realise that it was over-processing and overproduction that we were at a loose end with here. The outcomes. So as you can see, massively reduced where we're recording our data, and the nurses' view of the system has improved. Really hoping with, as we only ran the pilot in July, that in August, as they get to grips with the system and build their confidence with it, that it will that score will improve, especially when it comes to submitting audit data nationally. Now we can pull reports from the back end of Chemocare about exactly which patients we're seeing go into hospital and which regimens and which adverse events they're experiencing. So it will be really helpful to advise and input to research nationally about what our patients are experiencing to try and tailor our chemotherapy even more to the patient. So what went well? It was great working with the nurses. I work clinically in paediatrics, so paediatric hematology mainly. So I massively increased my knowledge of the adult area and what they're seeing in the GI team. It was really good application of the LIM tools, and in time, I hope it will have a big reduction in cost saving for the nurses on J80 and time saving as well. So yeah, really good to see the harmonization of processes. What we'll do differently, we found it really frustrating working with the Chemocare developers, CIS Healthcare, to try and align the CCCAE categories. So this is what we use nationally to record our adverse events for our patients. Obviously, it would not really be applicable to start recording adverse event data when a patient has died, as you can see here highlighted in green, but they still think that's appropriate, which did frustrate myself and many of the nurses. I'd also time my direct observations in the future so we could get that extra metric when looking at outcome data. Yeah, so we're hoping to roll this out into other areas. I know that our Nova nurses and some of the other tumour site areas are really engaged, and we're going to look to do that in the next couple of months.
Fantastic, thanks, Fran. That's a great piece of work. Great for your. I think that's been part of your own training. Is that right? So I think it's been really good to hear about that. And you clearly enjoyed doing it, as well as the great outcomes for patients as well. So that's good. That's great. So thank you. We've got a bit of time for questions on three really great presentations. There were Helen around the RPIW at Chapel Allerton, Bev, Nalini and Claire around paediatric theatre start time, and Fran around the really important work around chemotoxicity interactions and how we can think about that more safely for patients. So let's open it out for questions, please. Magnus.
Thanks, Phil. So thanks all, three great presentations. Can I just talk to Helen?
Yeah.
Helen, tell me about the 9 minutes. That scared the living daylights out of me. And then will you explain what a Trello board is?
Right. The lead time, we work with NHS partners, and they direct the flow of prescriptions at the start. So they are dispensing the rheumatology drugs and they're delivering them into the patient's home. So the lead time went from 24 days down, and it stabilized at 9 days. But if you keep a continuous flow, we aim that what we could start, because we're all in one room, is what we do is it's prescribed by the nurse prescriber, it's validated by the pharmacist, and then a purchase order is raised. So if you do an individual prescription, and that's all about what Kaizen is about, doing an individual prescription, you can bring it down to 9 minutes. But because there's still bottlenecks in the system, and that's what we've got to work out. We need to make sure that the original aim was it was 16 days, bring it down to 13 days, but we've actually got it stabilized that from the start, when a prescription comes in from the home care companies, it has that's when we start the time rolling, and we've brought it down from 24 days lead time right down to 9. It's stabilized at 9. I hope that explains that part of it.
It does, thank you.
The Trello board, I haven't quite got my head around it, but my manager, Russell Kay, is very good about Trello boards, and that's how he manages it. And he's spread this all around pharmacy about things to do and online communication, so that everybody's got access to Trello boards. Everybody knows what everybody else is doing, and it's just an online communication logger and a jobs worker. And it's just because of the communication, people in the first 30 days were still talking, in little groups and making decisions on their own. And for me, that it needs everybody engaged to do it. So everybody needs access, everybody needs somewhere to go to find out what the up-to-date thing is. And rather than having a notice board, which would have happened 20 years ago, you need a Trello board, you need an online communication. So for me, we might not get that done in the next 30 days, but I think I'm going to ask Russell to come on before the 90 days are up and teach us how to use Trello boards, because he's taught most of the pharmacists in Chapel Allerton how to use Trello boards. I hope that explains it.
It does, thank you. I think I've got more of an idea.
Yeah, brilliant. Thanks for that, Helen. Magnus. Any other questions? I just had one actually, probably for all three teams presenting, for Fran, Helen, and the Peds Theatres team, but quite a lot of joining together to do of different groups of people. What are your reflections on how you've kind of gone about that? Is anything we can all learn across the organisation about getting groups of people who are kind of working hard in their own area to come together to tackle a slightly different set of problems?
I'll probably mention that first, because I think that was the biggest challenge, because we've got a number of different professionals, and I was amazed at the people that got involved, from the prescription management team in rheumatology, who are the administrators who deal with the home care companies and manage the flow. They were so engaged at the start, and they had to make the biggest moves to come down to the hub from the area where they were working. And so the first 2 weeks, there was a bit about the room was too small, and it's actually in a room where an outpatient clinic is being used on 1 day a week. So that was a sort of a barrier. So that's what made Linda look into getting extra space. And for us, I think my personal thing, I haven't talked to the wider team yet, just talked to Linda, is about making sure that everybody knows what's going on, because that's the only thing to promote patient engagement, or staff engagement, and more patient involvement.
Great, thanks. Claire, Nalini, Bev, or Fran, any other thoughts from the work you've been doing on that question?
I think it's about keeping the conversation going with all the other stakeholders and the different CSUs. I think that's the challenge. Bev and I work closely with each other, and we picked up all the low-lying fruits in our area, and now it's about engaging with the Children's Hospital, saying, well, how can we kind of make the ward help with the patient flow, and how, these are small things like making sure that the laptops that are not in use in some of the areas on the ward can be redeployed for medical use, and how we can kind of help each other with escorting patients down and finding out what are some stumbling blocks at their end are. Bev's been engaging with the pediatric surgical matron, And we've been doing a lot of work with the pre-assessment nursing staff on the children's hospital side. It's how we actually work together, and it's good. It was good to have a common forum, but then engagement from some of these CSUs slowly petered out. And it's how we get a task force, if you may, together to make this an agenda that is important, not just for our patients, but also for all the other employees in the organization as well.
Really helpful. Really helpful.
I think what we also identified was that theatres were doing some things to keep the flow going, so they were backfilling the shortfalls. And whilst that, if you've got the staff to do that, then that's absolutely fine. But we're just targeting ENT lists at the minute. So if we roll that out across 7 theatres and all the specialities involved, we wouldn't be able to do that. So it's identifying what theatres are picking up that, and actually not theatres' role, if you like, but it needs to fit into the bigger scheme of things. So we're also able to look at those and address those issues as well.
Yeah, thank you. That's really helpful, and that scale-up challenge, you know, is a big thing for us still to think about. Fran, any thoughts from you?
I think for me, with it being a digitalisation project, the irony that physical presence was actually key to helping us drive things forward, especially when my clinical area of specialty is different to that of what I was working in. So that was what really helped me, and I hope will be helpful in future when we roll it out into different areas.
Okay, great, fantastic, really good reflections and thoughts, and 3 absolutely brilliant presentations right at the heart of delivering a better patient experience, but also making working lives so much better for our hard-working staff. And I think that's that bit about adding value and making work rewarding so that we can give better care is something that's really important currently, and really great to hear from all 3 of you to come through with the work that you're doing. So well done, brilliant stuff. Look forward to 60 and I think the 90-day report out, and Fran, thank you for presenting that work you've been doing. So we'll bring report out to a close. Thank you very much, everybody, and thanks to the team for presenting. Cheers. Thanks.